Hello everyone, welcome to our new webinar, Treating the Brain and Not Only the Hand. For someone, I think it's better to say good afternoon instead of good morning. For this, I would like to let you know that we are almost 100 people already connected with us. So thank you very much to all the participants to this webinar. My name is Luca Bertoni. I'm the sales representative and product specialist for the Gloreha Rehabilitation products. We are broadcasting from Italy. We are so glad that you joined us for this very important occasion to know better to know more about our rehabilitation products. Today, we're gonna have special guests with us, so long-term Gloreha users around the world. We're so glad to welcome Mrs. Tatiana Jeglic from Slovenia. She's the head at our own Center Physiotherapy Ljubljana in Slovenia. And other participants like Dr. Jucilin and Mrs. Cynthia Lee, representatives for the Center Taipei Shuangho Hospital in Taiwan. Okay, so what we're gonna do today altogether, we're gonna learn a lot from the direct experiences of these professionals, their direct experience with Gloreha, on real patients, of course. So in the first part, Mrs. Tatiana gonna teach us her direct experience with Gloreha devices on real patients with direct results after the usage of our products, but also after the usage of different techniques during her treatment with her patients. And in the second part of this webinar, you're gonna discover the results that Dr. Jucilin, Mrs. Xinqin and Mrs. Fengli Guo obtained on adults and children. So you're gonna discover a couple of studies conducted on adults and children using the Gloreha devices. Please take note about many possibilities at our disposal today. We want you to be active part of this webinar. So in a few seconds, I think that you should see a pop-up to let us know and our guests, Mrs. Tatiana, Dr. Jucilin, and Mrs. Cynthia Lee, about you, to know more about you, who you are, what's your role in your company or in the hospital you work. And later on, of course, your participation is required. So pay attention during our webinar because you will be tested. But don't worry. Please feel free to answer our questions. And about questions, of course, please remember that there's a dedicated section, question and answer section, in which you can type your questions to our guests, to our today's guests. At the end of our webinar, which will last more or less 1 hour, 1.5 hours, we won't bother you, we won't stress you too much. Please stay with us. You will have the possibility, along with me as a moderator for this webinar, to ask questions to our panelists, to our guests. So feel free to type your questions in the dedicated section. Okay, so I think that we can start with Mrs. Tatiana. Just a recommendation to Tatiana, but in the meanwhile, the results are coming. So the majority of our other guests are physiotherapists, occupational therapists, neuropsychologists, engineers, students. Okay, there's a very various group of people today. So once again, thank you so much for your participation. I think we can also see the result, yes, on the usage of robotic devices in your professional activities. Yeah, the majority of you probably is not is not using robotic devices. So this is a great occasion to hear from people using on a daily basis the Gloreha devices and in general robotic devices. So great occasion for everyone. I think also for us, we are very excited. Thank you once more for joining us. I would like to say to Tatiana the quick recommendation about the possible video that you want to let us watch about the sharing of the screen and the sound to activate about the sharing. Okay, that's it.
Okay.
Excellent.
Good. Thank you very
Okay.
much, Luca, for this introduction. Can I start? Yeah. Okay, now just a second. Just a second, because I have to display. Okay, Luca, do you see the presentation?
Yes, perfectly.
Yes, okay. Thank you.
Excellent.
Thank you. Good. Good morning and good afternoon from my side as well, and hello from Ljubljana. Today's title is very broad, and in 30 minutes I will cover only a few points of the title. I have chosen this title because the lesion of the neurological client is in the brain. So in the therapy, we need to have in mind that we need to reach the brain function through the body function. When I'm treating the client, I always think about the task, the environment, and sensory, what this task, the environment and sensory input means to the brain. And what is the outcome of the chosen task, structure, and environment, and of course, the facilitation, so the motor performance of our clients. Whenever I am lecturing about the hand, I am always telling these sentences because it's very nicely said. So the hand has several advantages over the eye, and it can see in the dark and it can see around the corners. Most important of all, it can interact with the environment rather than just observe it. So the hand is very important for our sensory, for our central nervous system, in detecting the recovery of postural control on upper limb function. We need to consider that the important role of the hand as a large sensory organ that influence the hand and the upper limb postural orientation and the holistic nature of postural control obtained from the whole body. So the hand is not just representing the ability to reach and to grasp and manipulate with the objects. It represents extensive sensory information from the central nervous system. For me as a therapist, when I'm talking about the hand, I always have in mind as well the upper extremity, which is transporting the hand into the space, so reaching, and of course the trunk, which represents the dynamic stability of the upper extremity. In these days, we know much more about what causes the stroke than what causes the recovery of the function. Traditionally, we often divide the recovery into stroke phases. So hyperacute, acute, early subacute, late subacute, and chronic phases. And this classification, a lot of times, carries particular risk of considering functional recovery as a clear-cut sequence of phases rather than continuous non-linear process. In the study, which was done by Van der Wilet and their colleagues, they sampled 412 ischemic stroke patients based on Fugl-Meyer upper extremity score. Patients with mild initial deficit make an average better recovery than the patients with a severe deficit. Different colors in this graph represents different recovery subgroup based on the longitudinal mixture model, which they discovered, or they put it into the The number of the left side of the graph represents proportional recovery coefficient, which donates how much of potential recovery has been achieved based on the Fugl-Meyer upper extremities score. The downward arrows, which you can see in the bottom of the graph, indicates the time consistent, so how fast patients recover. But we can clearly see that severely affected patients, this is the green curve, can achieve a good outcome as well with a relatively high recovery coefficient, but in a longer time compared to the other subgroups. So if the client is more severe impaired, it does not mean that he doesn't have potential for the recovery. It just means that sometimes they need a little bit more time than others. So these studies are telling us that we need to be very careful with what we are saying about how much potential our clients have. In order to achieve the rehabilitation, or in order to achieve better outcome performance, we need to involve a more affected hand in the therapy and teach our clients how to use both of their hands. So in that way, we can obtain behavioral recovery. In the article published in 2014, they have reviewed 138 randomized controlled articles, and the aim was to explore the relationship between the schedule for the therapy and improvement in motor therapy for adults after stroke by comparing high dosage to low dosage. The conclusion of the systematic reviews were that the higher dose of therapy has a positive effect of the functional outcome. And dose in this research was defined as a total time schedule for the therapy, like 3 hours per day for 10 days. That means 30 hours of rehabilitation. The timeline of intensive rehabilitation does not play a big role, and that the Rehabilitation Institute and the therapist should consider different ways to increase the therapeutic time, both inside of the therapy, so inside of the institute, and outside from formal therapies. So that means in the client's home. In many institutes and many clinicians or therapists, we are limited with time. So that is why we need to find another way to increase the repetitions. And robotic assisted therapy and transfer packages could be the way to do it. There is another research which is talking about how much the physios and OTs are practicing the upper limb activity during the 30-minute session. The study was conducted in the Netherlands in 2016 and in 3 rehabilitation centers on people with severe upper limb and arm impairment. And what they have found out that PT and OT perform therapy on average 4 to 7 minutes in 8 weeks of follow-up. OTs deals much more with the upper limb in the activity level, while PTs spend more their time dealing with the body function and structure. And that is contrary to the clinical guidelines, which recommend that the therapy should be focused as possible on the level of the activity and goal-orientated at the same time. the therapy should be high intensive and challenging for the clients. And I have to say that unfortunately in Slovenia, this is not the case. Another systematic review from 2015 about the dosage of activity-related arm training during the acute and subacute rehabilitation revealed that during the PT session, activity training was obtained between 4.1 minutes up to 5.7 minutes, and during the OT session, up to 11 minutes in acute rehabilitation. And during the subacute rehabilitation, activity-related training was on average undertaken for 4 minutes per PT session and 17 minutes per session during the occupational therapy. This is very, very low. This systematic review found that repetition per session were reported by 2 studies only during the subacute rehabilitation. One study reported 23 repetition per session during the physiotherapy and occupational therapy, while another study reported 32 repetition per session across both disciplines. And we know from the clinical research that animal models suggest around 400 repetitions per hour to facilitate neurogenesis and neuroplasticity. So 23 or 32 is it's not enough in order to achieve the neurogenesis and neuroplasticity, and it's not enough to change the behavior of our clients for using their more effective hand in the outward. The study compared, this study which you can see, compared the motor intervention and the grip behavior in people with stroke with ipsilesional arm in 2 situations. We all know that better hand or ipsilesional hand is not good hand. And this study was focusing on 2 situations, therapeutic situation. So the laboratory therapeutic behavior and more functional or live behavior, where they had to follow certain objects on the screen and also receive a reward for the achievement. So this is more live situation, right? What they have found out that intervention and grasping with the ipsilesional arm is impaired or deviated from normal compared to the control group, which was equal in age and dominance. And there is a lack of coordination between transport and grasping as a significant deficit in a more sound hand. Motor deficits are more obvious and more pronounced in natural than laboratory context, and that assessment and the rehabilitation should focus on the analysis and therapy of everyday natural movements of intervention and grasping, rather than just laboratory-orientated motor patterns. So more goal-orientated therapy using the real-life objects. That could be the conclusion for that from that study. In order to achieve neurogenesis and neuroplasticity, we need to practice. So we know about the 10 principles of neuroplasticity from the Clyment-Jones in 2008. More motor functions are using quite similar patterns, so motor functions for the upper extremity. So reaching towards the glass of water, or reaching towards the toothbrush, or reaching towards the knife or fork has quite similar motor patterns. And as a therapist, we need to analyze the motor activity so we can determine which component of the part of the body or upper extremity is more impaired. As well, we need to analyze which body function or body structure is mostly impaired. In a clinical examination, we have to be very thorough, and we need to do the tests on different levels, either on body function, body structure, on a particular participation level. This is what we are doing in our clinic. First of all, we assess the client, how they are reaching, how they are using their arm, what are body impairments, body function impairments, and in that way, and what is the goal of our client. So in that way, we can really individualize the therapy program for that particular client. There is always a question in the therapeutic world, which therapy is better, the unilateral or bilateral movements of the upper extremity. And we know that everyday life activities includes both of them, like cooking or personal hygiene, for the feeding, for the toileting, carrying objects, driving, using modern technology, etc. So facilitating participation of the patient and ability to resume their life roles. When I went through different studies, for the unilateral upper limb training, they have mostly include a repetitive task-related training and constraint-induced movement training and unilateral robotic-assisted training. And for the bilateral training, they have been using more bilateral robotic-assisted training and bilateral arm training with the rhythmic cueing. And systematic review from Ping Chen and colleagues published in 2019. They include 21 studies involving 842 subjects with the stroke. They compared unilateral to bilateral training, and they have found out that bilateral training yields superior improvements in the improving of motor impairment of people with stroke by as measured by Fugl-Meyer upper extremity score. But however, these strategies did not yield significant difference in the terms of functional performance of people with stroke by measured with Wolf motor function test, ARAT test, and box and blocks test. So that means that in the therapy, we need to consider both of those training. We need to focus on unilateral training, and we need to focus on bilateral training. Because everyday activities, they are using both of their hands. We are not using just one of our hands most of the time. Now let's talk about action observation therapy, which could be another way to reach the brain. So the activation observation therapy is dynamic state during which the observer can understand what the other is doing by simulating the actions and outcomes that are likely to follow from the observation of the motor act. So if I'm observing the ability to reach, to grasp, and to manipulate with an object, I am activating my, mirror neuron system. So my synapses are active while I am observing. So this is the other way to use the sensory input in order to facilitate the neuroactivity in the brain of our client. Action observation therapy commonly includes action observation and action execution, and allows patients to safely practice movements and motor performance. So in our intensive programs, we are using our intensive program now for 9 years, and we are developing our intensive programs from each year, because we are trying to follow the research conductions, and we are trying to incorporate the neurophysiological and neuropathological knowledge. We are specialized in the rehabilitation of stroke survivors and other clients with neurological lesion. Our intensive programs, our clients are in our clinic for 3 hours per day, every working day for 3 weeks. So the basic of our intensive program is Bobat concept, and we are including constraint-induced movement therapy programs for the upper and lower extremity, motor imaginary behavior therapy, task-oriented therapy, robotic-assisted therapy. We are using Gloreha for that, the Gloreha device for that robotic-assisted therapy. And we are using the sensory education program, Tip Steam Glove. It all depends on the client impairment and the client ability and the client's focus, what they want to achieve after the stroke has happened. They have to sign the behavior contract, because in that way we know that we can reach towards the more repetition per day, and we can really transfer the ability of using their hands in the everyday life situation, so at home, in outside world as well. We are outsourcing different specialists. So the speech therapy therapists, we have kinesiotherapy, we have lymph drainage. We are working with the engineers of orthotics and prosthetics, and we are working with the clinical psychologist as well. So if the client needs any of these professionals, they can have it. Before, I have to emphasize that the Gloreha, or the robotic assisted therapy, is an adjunction to our therapy. So if we are talking about 3 hours per day, most of the time our clients have the robotic assisted therapy, so with Gloreha devices, for about 45 to 1 hour per day. It depends on the level of client ability. But before we put the client on the Gloreha, we try to facilitate, and we try to teach the client how to use their hand. We are trying to facilitate different selective movements in the hand and in the upper extremity as well. So here I will show you the teaching how the client can or how she's able to perform the extension in the thumb and reposition, and another video I'm showing you how the client is able to hold the dorsiflexion and extension in the fingers. After the repetitions, few repetitions, and teaching them to be aware of the movement, so where the movement starts, which muscles have to be involved, then we obtain this motor performance. It took us approximately 15 minutes with this client. So here you can see that she is able to hold the position with less of my facilitation, and she's able to lift the hand in the wrist as well. And after so this is the first task that I've been showing you before. So the extension in the thumb and reposition of the thumb as well. So you can see that this client, she has the ability to learn. She has the ability to do the selective movements. And after that, we put the client on the Gloreha, so she can practice more and more and more. We all know that repetition matters, right? In these videos, I'm going to show you, it was the first time that our client used the hammer, and he was building his own therapeutical object, because after that he was using this therapeutical object in order to practice the pinch movements in the fingers. We are always using the facilitation in order to gain more quality of the movements. So you don't hear, but you can see how the rhythm of the hammer with the facilitation of our therapy. So we are using bilateral and unilateral training, right? He is a carpenter, so he is using the hammer. He was using the hammer in his life before. So this is the after few repetitions. So you can clearly see how he gained more and more speed in order to put the nail into the wood. During the therapy, we need to, the therapy needs to be playful and has to reach towards the positive feelings. So in that way, we facilitate dopamine and serotonin. So you can see how he was happy, how he was laughing. And dopamine and serotonin, they facilitate motor learning. Okay. And I'm sorry. No. And some, no, what's that? No, sorry, it is not a video. I thought it's a video. In this picture, we can see that sometimes we are using restraint in order to facilitate other movements. And because we know that in our body, if something doesn't move, something else will, right? So we are trying to restrain the part of the body or the part of the hand which should not be moving while performing different motor tasks. No, sorry, now I have to go forward. Okay, good. So why Gloreha? Why I have chosen Gloreha device for our therapy intensive programs? It is a robotic assisted therapy which allows the reaching and grasping and manipulation with the real objects. That is very important from my point of view as a therapist. It is very light and it can facilitate different selective movements in the hand. As well, it can facilitate different grasps of the hand, so power and precision grip. And it allows manipulations with the real objects, so the task-orientated therapy. We can practice unilateral or bilateral or bimanual functional tasks with Gloreha. It is action observation therapy and problem solving in order to complete the task. So the program of the Gloreha allows different settings individualized for the special client. So we can increase or decrease speed of movement, increase or decrease range of motion. We can put the reference framework for the screen on the screen for the attentional problems. We can differentiate levels of the difficulty. We can different areas of the upper extremity, forearm, wrist, or the hand, so that the client will be able to perform the activity either with only the hand, upper extremity, the movement of the upper extremity, with the forearm, so pronation, supination, with the wrist, or with the fingers as well. So it all depends on the client level of ability and performance, and what we as therapists think that he needs to practice more and more and more in order to use their hands in the real life situations. What I really like about Gloreha is a dynamic arm support, because it's taking the weight of the upper extremity. So this is the facilitation technique, right? So they are able to move their upper extremity in the space. In Gloreha devices, you can choose the tasks, or you can choose the games. And it's challenging and motivating for the client. Here is the video of our client. He had stroke and traumatic brain injury at the same time. And for his hobby, he was riding the horses. So I chosen to use the brush for the cleaning of the horses. And he was practicing reaching and transferring this brush into the environment. All right. Good. All right. And you don't hear it, but I was guiding him through my vertical cues, what to do, not to move the trunk, only move the hand towards the brush. This is the video of our recent client. He is 71 years old. He's not playing the computer games, and I didn't know if this would be a good idea for him. And I said, what the heck, let's try. And he was really happy, and he was laughing. And you can see my finger on his shoulder, because before he was initiating the arm movement through his body, not so much from his hands. So with the Gloreha devices, we can be there, we can facilitate the real movement or more quality movement. I really recommend you that you are in the place in the therapy room when the clients are using the robotic assisted therapy, because otherwise they will be compensating, and this is not it's not good for the quality of the movement, right? So here you will be observing how much he learned not to use his trunk in order to move his hands, and that was only after 10 minutes of the therapy. And I chosen the game with the mushroom because he goes to the forest and he likes to pick up the mushrooms. So it was familiar task for him. In our clinic, we always do the outcome measures before we start the intensive program and after we finish the intensive program. Here you can see the graph of one of our clients. The graph, the light gray are results before the intensive program, black are results after the intensive program. You can really see that the client was more successful in the Wolf motor function test. He was much more successful in the motor activity log. And he was very successful with the ARAT different, with the power grips, with the cylinder grips, and especially with the pinch movements. In the next, and this client or every client is wearing Migo. It's a watch which is, it counts repetition of the upper extremity during the whole day. So you can really see how much the client was using more and more of his impaired hand during the whole day in this 3 weeks period. I was talking about this client. This is the, he was 41 years old when he had a stroke, and you will observe the pinch movement in the ARAT. This is before we start the therapy program. You can really see how he's trying to grasp the small ball. He's using his whole body. He's using his shoulder. He's using his hand. If he wouldn't have the mask on, I'm sure that we will see how he would be moving the mouth in order to grasp this small ball. He was really, you can really see how his brain is trying to figure it out, how to perform this task. And at the end, he just stopped and he said, no, I cannot do it. And in this video, the second video is the video after the therapy program. Yeah, and yes, he was able to hold it and put it on the higher level. So we were very surprised. We were very happy. What is our aim as a therapist? Our aim as a therapist is to challenge motor behavior of the client. Our aim is to teach them to solve motor problems in everyday life activities. Our aim is to use their abilities that they have in their brain and in their upper extremity. And our aim is to achieve and take control of their life after the brain lesion. So this is the last two videos. This is what is very important for me as a therapist, that the client is able to perform everyday life activities, either with only one hand, so unilateral movement, or with both of the hands, so bilateral movements. Okay. Okay. That is it from my point of view. I hope I was not too long. Okay.
I think not, Tatiana. You did great. Thank you so much for your excellent explanations and testimonies about real-life patients with their recovery. I feel really impressed by your videos, especially because I was not aware of also the recent patient who tried to use the ARIA, for example, so the games we included in our robotic device. I'm quite overwhelmed by this, because the before and after confrontation also is really significant. So thank you so much. Also your ability to resume everything. I know that there was a lot to say from your side, because you have a long experience with and not only with the Gloreha devices, but also with the rehabilitation on his own. So great first part of our webinar. I think we also overcome the 100 participants, so we are even more than glad about this, because many people had the opportunity to hear from you, to know about your long-term experience. So in the meanwhile, I am addressing to our participants, to our attendees. Please, if you would like to type your questions in the questions and answer section, please feel free to do it. Don't be shy. We are at your disposal. Also consider that we are at your disposal after the webinar. So if you want to keep in touch with us or indirectly with Tatiana or our Taiwanese professionals that we're going to see in a moment through the video interview, feel free to do it. Keep in touch with us. We want a continuous exchange with professionals from around the world. So we want to grow up with you, because we are a young company. We started our activities in 2011. So there's still a lot to do. We can grow more thanks to you professionals. That can give us tips, suggestions on how to develop even better our professional solutions, just like Tatiana and the professionals from Taiwan did in the past. So we hope that once you may join us in the Gloreha family. So this webinar was a great occasion to do so. Let's try to keep in touch also after this webinar. Okay, in the meanwhile, the questions are coming, so we're so glad about this. But we keep going on with our webinar. So let's pass to the second part of our webinar. It's a video interview to our professionals from Taiwan, conducted by our colleague, Mr. Daniele Chiodi. It's another significant testimony and interview about clinical studies conducted, as I told you before, on adults and children using also, especially the Gloreha devices. So in a few seconds, you're going to see this video interview. Thank you.
So we are here today with Dr. Yui Lin, Master of Department of Health Business Administration at National Taipei University of Nursing and Health Science in Taiwan. Which protocols and inclusion criteria have been used to conduct both studies?
First, the protocol between the two studies. In a study with adults with stroke, the protocol is the subject receives 60 minutes of robotic therapy or conventional therapy twice a week for 6 weeks, with order of treatment counterbalanced after a 1-month washout period. The performance was assessed at 4 time points: robotic therapy pre-test and post-test, conventional therapy pre-test and post-test. In the study with cerebral palsy, the protocol is the subject receives 12, 16 minutes robotic sessions 2 times a week. And the performance was assessed at the pre-test, post-test, and 1 month follow-up. As the inclusion criteria, in a study with adults with stroke, we include the subject who had a first stroke with hemiplegia and who had a subacute and chronic stroke could understand our instructions and were in Brownstone stage 2 to 5 of recovery. And the subject has sensory impairment. Also, the subject had muscle tone allowing movement. And we exclude the subject who were aged below 20 or above 75 years old. And we exclude who were unable to clearly see or hear the feedback from the device, or who had other medical symptoms. As in the cerebral palsy experiment, we include the subject with diagnosis of cerebral palsy or cerebral injury, and the subject current age of 6 to 80 years old. And the subject may have the ability to understand 2 steps order, and they are no Botoxing injection received in the previous 6 months. And they were medically stable and had the ability to maintain a static sitting position in a wheelchair or in a chair. The experiment excluded the subject with other neurological, cardiovascular, or muscular disease that could affect movement in this study. And visual or auditory impairment prevent the patient see or hear the feedback from the device clearly.
Hello, here we have Xin-Shi Li, Master of Physical Therapy and Assistive Technology at National Yangming University in Taiwan. Which evaluation scales do you apply?
Yes, all the patients were assessed that consider the ICF domains. For body structure and function, we assess the Google Mile assessment upper extremity for motor impairment, and we also use the EMG for muscle activity. And we use the bus and block test for unilateral manual dexterity. And we also use the grip dynamometer for grip strength. For activity and participation, we use the LB hand keys for ADL function. All of the evaluation scales are commonly used and according to previous similar study.
Concerning the crossover studies on adults, which differences in terms of outcomes appear between the 2 groups?
In outcome appear between the 2 groups, we have found a significant time effect was observed in the rubber-assisted therapy group for proximal and total score of Google Mile assessment upper extremity. And we also found a significant group effect was observed for the peak value of the extensor digital communities during the small block grasping task. And regarding ADL function, we found a significant time effect in the modified Basel index scale of the robot-assisted therapy group.
Which implications of robot-assisted therapy for the occupational therapist practice?
The implication of robot-assisted therapy for occupational therapy practice in people with stroke and cerebral palsy are 2 points. The first one, a task-oriented approach combined with use of a Gloreha device can facilitate whole limb activity movement and efficiently improve functional recovery. And the robot-assisted rehabilitation improving hand extensor muscle control could effectively reduce synergistic pattern and reconstruct movement patterns. We think interaction with real objects is very important for motor and sensory recovery. The robotics device, which focuses on the distal part of the upper limb and use a dynamic support system that could combine the task-specific training with real objects, make training playful and motivating. And the context is similar to the real world that could simulate the ADL task. We believe the intense motor activity practice and multiple sensory stimulation, which can establish and reinforce neural pathways to facilitate motor and sensory recovery.
We are here with Mrs. Feng Li Guo, Master of Physical Therapy and Assistive Technology at National Yang-Ming University in Taiwan. How does Gloreha's active assisted therapy fit into the neurological rehabilitation context of adults and children?
We will do a comprehensive evaluation first. According to the ability of a hand, we would select different active assist therapy mode. The hand movement involve different degrees of opening and grasping. We also could adjust the parameter of active assist mode, include the range of assistance, waiting time for assistance, continued or segment assistance in the active assist therapy mode. Robotic assistive therapy could provide amount of repeated practice. The visual, auditory, and proprioception feedback could increase the motivation and the effect of motor learning. The auditory cue could provide a good response of subject, and the visual proprioception feedback provide a good awareness of hand movement during the robotic therapy. Therefore, the subject can make better motor pattern of hand.
What impact does Gloreha bilateral therapy have on recovery of adults and children?
According the frame of reference for neural development treatment, bilateral therapy test-oriented approach, we facilitate the hand movement by bilateral therapy mode. When both arms and hands executed bilateral symmetric movements simultaneously, the template generated by the undamaged hemisphere may provide normal motor plans to assist in restoring the movement pattern of hemiplegic side. The possible mechanism underlying the positive impact of bilateral training is the alteration of intracortical inhibitory circuit between the hemispheres, which then permit inter-hemisphere facilitation of limb movement. So we use the bilateral therapy for the subject with few active movement, such as non-voluntary grasp or non-voluntary opening hand movement, like one strong stage 2 or 3 of a fatigue hand.
Which is a key feature for a successfully robotic therapy?
We think the key feature of successful robotic therapy is massive practice and cognitive engagement and functional task training, a combination of a virtual scenario and task-specific training, makes training playful and motivating.
So we had the opportunity to see this video interview. In my humble opinion, very significant, as well as the testimony coming from Tatiana. So a couple of tips and speeches, very important to us, but also to our attendees today. Okay, I think that the next and last session for today's webinar is about the question and answer section. We notice also behind the scenes that Tatiana is so proactive and cooperative okay, she already tried to answer the first questions. Of course, we would like to share these questions and answers with everyone with us today. In the meanwhile, I read also congratulations for this webinar. So thank you so much for Tatiana's presentations also coming from Susan Pordy. Okay, there's also a question coming from Susan. I think is directly addressed to Tatiana. So do your clients also work independently in that to the 3 hours per day that you mentioned? Yeah, we think that the answer is yes. I don't know, Tatiana, if you would like to answer for everyone, okay, to share your experience.
They need to practice when they go out from my clinics. So in the behavioral contract, we are signing what they will be doing with their more affected hand or with both of the hands during the day lifetime activity. So like every time that they go through the door, they have to open with the affected hand, or they have to carry the objects, or they have to wash their hands, not just, wash with the sound hand, but really try to move the affected hand around the sound hand. And they have to wear the restriction glove, and they have a 30 minutes training program addition to what they are doing in our therapy.
Excellent, excellent. In the meanwhile, of course, I can say hello to our great professionals from Taiwan. So Dr. Juichi Lin and Mrs. Xinqie Li. Mrs. Feng Li Guo, I think that for pandemic reasons today couldn't join us. It's a situation that is affecting everyone in the world, as you well know. So I kindly ask you, Dr. Juichi Lin and Mrs. Xinqie Li, to activate their audio and video so that we can interact with you. Everyone can virtually say hello to you and see you. Thank you very much for joining us today.
Hey.
I know that the situation is not easy, as I mentioned before, but thank you for your participation and for this great video interview that you gave us. Okay, there are other questions, so I think I have to pass through the other ones. I have Siarifa Siadza Nadia Tombezar, who's asking, may I know inclusion criteria for patients that are suitable to use Gloreha? It is suitable for moderate or severe spasticity or less than that? I think that this question is shareable between you. Okay, so it's for everyone, for Tatiana and for our Taiwanese professionals. So the inclusion criteria for patients to use Gloreha. Yeah. I don't know if you want to start from the Taiwanese
yes,
professionals, just to alternate as you wish.
In our study, our inclusion criteria for stroke, they have to bounce from stage 2 to 5, and their muscle tone allowing to movement not too high, and the visual and the here they can hear the feedback and they can see the feedback from the device, and their medical symptom is stable. And in cerebral palsy, the inclusion criteria is also the same. The cognition is have to understand the the following step, and they don't have to they don't need the muscle tone need to low, not too high.
Yeah.
And the medical stability, and they could maintain a static sitting balance. Yes, that's
Okay,
all.
excellent. Yeah, excellent. Tatiana, would you like to add something about your experience?
Yeah, from my point of view, a lot of clients, even the clients with a little bit higher tone, can be can work with Gloreha. So the passive move, the passive the workstation, right? As you recommend, it should be the mass array grade 3, as I recommend,
Yeah.
as I recall. But what I a lot of times do is, especially because the tone itself, it can be really high when you are expecting something. So if the client is able to be very calm and reduce the tone, it can. I put them on the Gloreha as well. So it is quite suitable almost for everybody, almost. But with the mass tone 4, 5, yeah.
Yeah. Okay. Excellent. Yeah. Excellent. Okay. Okay. Let's go ahead. Thank you for this webinar from Matarawat. The question is: are there other strategies you use for flaccid hand? So not spasticity in this case of flaccid hand. Great question.
Yeah.
As you wish, Tatiana, if you want to start. Excellent.
Yeah.
Okay.
With the flaccid hand, we are using a lot of different techniques in the closed kinematic chain in order to try to gain more dynamic stability proximately. And with the Gloreha, what we are doing, we are using more dynamic arm support. And there is a splint that you can use for the wrist. Or additionally, what we are doing, if the flaccid hand is very, very flaccid, we are building their own splint from the different very soft material and material. So yeah, with the flaccid hand, a lot of time the cognition is very low as well. So we are using the Gloreha for the cognition part as well, not just for the hand, not just for the mobility of the hand, but in order that they are more focused, that they are following the task on the computer. So it's both, not just motor and the cognitive as well.
Xinjie or Ricky, our friend Ricky, would you like to add something about flaccid hand? Otherwise, I have a question for you, specifically addressed to your studies conducted using Gloreha. Okay, Sujata Misal, sorry for these pronunciations. I'm trying to do it as best as I can. At what brownstone stage of hand do you start with Gloreha? So you mentioned it before, the brownstone stage. So when did you start? What stage do you start along with the Gloreha?
So,
can you hear me?
Yeah. Hey, you mean the stage to start with the Gloreha?
Yeah, according to the Brandstrom, yeah, scale. Yeah.
Okay. In our study, maybe we start with the stage 2.
we didn't try for the bronze tone stage 1. Maybe we should do I don't know how to say. Maybe we should try for stage 1 because in the flaccid client, maybe we can treatment through the passive movement and with the action observation, maybe there will be some help. Yeah. Okay.
Excellent. Excellent. Thank you. Thank you, Ricky. Thank you, Dr. Juichi. In the meanwhile, I'm reading other requests. Some are commercial, so maybe we can keep in touch with people asking for prices and so on. But keeping our webinar from a clinical point of view, I'm reading, this this question coming from Tunahan Ilmaz. It is important for patient to use his hand while practicing activities with Gloreha. It is a must, or it is possible not to show the hand? Yeah, great question.
Sure, it's a possible not to show the hand.
Yeah, of course.
Yeah.
This is a possibility of customization of Gloreha.
Yeah.
Of course, we all learned that the combination of physical rehabilitation and the mobilization of the hand and the fingers, as well as a virtual reality coming from the screen, the PC included in the Gloreha device, may help activate the brain areas damaged by stroke, or to reorganize the brain areas damaged by stroke, especially those involved in the hand function, or those that can be reorganized to use the hand again. So there are a lot of possibilities to use or not to use showing a real hand or a virtual hand doing something. Yeah. Okay. I have a question coming from Vasilios Nikolakaros. After stroke, which is the specific time to give us positive clinical process for the hand? Yeah.
To give us possible clinical process, you mean what is the time framework for the to gain some activities back, to give the positive rehab also? Yeah, we all know that in the early acute stage, the client needs to be more still. So it is not recommended to do the intensive therapy. But in the acute stage, we have to start the intensive therapy. And as soon as we start, the better the results could be. So there's not a framework that would say, yes, after 1 week, you will get the positive outcome.
Yeah, I think that we have to consider, yeah, we have to consider the each case by case.
Exactly, exactly.
It. Yeah, okay. There are a lot of other questions. Okay, I'll try to read some of them before the webinar ends.
Maybe this one with the sensory issue from Ashira.
Okay, yeah.
Can patients with the sensory issue go on Gloreha? Yes, they can. Yes, they can. There's no contradiction with the sensory impairments. It is even useful to use Gloreha for the sensory impairment clients.
Yeah. Okay, I think that for questions of time, we have one last question, but of course we won't forget about all the other questions that we received. Later on, we can put in contact with our panelists, our today's guests. So don't worry. Meanwhile, I read the other congratulations. So thank you so much to everyone. Jigan Selvaraj is typing, what are the challenges that the center might face to implement robotic rehab technology? Great question. It's not easy.
Yeah.
Cynthia, would you like to answer?
Oh, okay. The challenge to implement the robotic rehab technology, we think because in Taiwan, we don't have the insurance to pay for this kind of therapy. They have to pay by themselves. So everyone have to pay by themselves. So they have to choose the effect of the rubber assisted therapy or not. Not almost everyone have money to pay this. So even the effect of the rubber assisted technology is very good for the stroke or other symptom. The implication is not very often in our patient of our hospital.
Yeah.
Yes.
Yeah, I think it's a quite widespread situation all around the world, thinking about insurance. And unfortunately, the choices that families, caregivers, and the patient themselves sometimes have to face to get the best rehabilitation according to their possibilities. This is, I think, a long way we have to work on, not only in Taiwan, but also in Italy, in Slovenia, everywhere else. I think we all can improve the conditions to treat as best as we can our patients. Let's hope to also from a governmental point of view everywhere to get better, to have a better situation, yeah, for this, for a better rehabilitation for everyone. Yeah.
Thank you.
Okay, I think we are at the end of our webinar. We saved all of the other questions to be answered. We're gonna try to answer by ourselves or with the help of our great today's panelists. So thank you so much to Mrs. Tatiana Jiglic, to Mrs. Cynthia Lee and Dr. Juichi Lin for their participation. Thank you all for your participation. We kept high numbers of attendees today during the whole webinar. Thank you so much. Please visit our website www.gloreha.com for further information, or directly contact us if you want to know more about the Gloreha devices. Thank you so much, and see you next time. Bye.
Thank you. Bye.
Bye. Bye.
Bye. Bye.